Bismillah ar-Rahman ar-Rahim. Management of exacerbations of cystic fibrosis. Pulmonary exacerbations are the most common reason for hospital admissions of cystic fibrosis patients. Patients are usually adept at recognizing a deterioration in their condition, requiring treatment, and treatment is usually required if they present acutely, even if they appear fit and healthy. Signs and symptoms of an exacerbation include increase in productive cough or dyspnea, a change in appearance or volume of sputum, new signs on auscultations, new chest x-ray changes, weight loss more than 1 kilogram or 5% of body weight associated with anorexia, fall in FEV1 more than 10%, fever. Persistent low-grade symptoms such as cough alone are an indication for IV antibiotics if oral antibiotics have failed to bring about an improvement. IV antibiotics should also be considered if a few positive sputum culture fails to clear with appropriate oral antibiotics. Investigations. Baseline spirometry for FEV1, measuring weight, autosaturation, and if below 92%, we should do blood gases, chest x-ray to exclude pneumothorax or new infection or consolidation or another problem in the chest, sputum microscopy culture and sensitivity, including specific testing for Pseudomonas aeruginosa and BC complex, and acid-fast bacilli, blood including C-reactive protein. Note, note that not all patients exhibit high inflammatory markers even during severe exacerbations. Monitor blood sugars. The treatment is with appropriate antibiotics according to culture and sensitivity or suspected organism. Doing chest physiotherapy or postural drainage, nutritional support and control of hyperglycemia, and any patient will self-administer IV antibiotic at home. Indications for inpatient treatment include 2 annual for home therapy, significant weight loss, poor response to recent home IV antibiotics, poor compliance or unable to self administer IV therapy, and patient preference, and if there is another complication such as significant hemoptysis or pneumothorax. If failing to improve with empirical antibiotics, review microbiology and repeat sputum microscopy culture and sensitivity and acid-fast bacilli, and consider empirical change in antibiotics including anti-pseudomonal cover. Consider hospital admission if failing to improve with home-based treatment. Optimize airway clearance with intensive physiotherapy and review mucolytics. Optimize nutritional support and glycemic control. Assess adherence to treatment and exclude allergic bronchopulmonary aspergillosis. Review and repeat chest x-ray imaging and consider CT chest followed by bronchoscopic lavage targeted to area of nodularity or consolidation on imaging to exclude non-tuberculous mycobacterium or fungal infection, stopping all antibiotics including long-term macrolides and nebulized anti-pseudomonas may increase bronchoscopic yield. Consider empirical oral prednisolone in severely unwell patients who are failing to improve with appropriate antibiotics. Non-invasive ventilation may assist with airways clearance in addition to providing ventilatory support. And consider the appropriateness of intensive care unit admission as well as resuscitation status in severe exacerbations and liaise with cystic fibrosis consultant or contact cystic fibrosis consultant. Now we'll speak about intravenous antibiotic administration. The majority of IV antibiotic courses can be administered at home or after an initial assessment and with home support from nursing staff, and many patients are relatively well during course of IV antibiotics and are able to continue attending work or colleague, although it can take them considerable extra time to administer the antibiotics. Most antibiotic regimes involve 14 days of IV antibiotics administered via a peripheral long line or implantable venous access device. Implantable venous access devices. Prior to starting IV antibiotics, clinical assessment, including spirometry, should be performed, and the patient should be reviewed at day 7 to ensure satisfactory clinical progress and to consider changing antibiotics if little or no improvement, and at end of the course in outpatients to ensure clinical improvement. Course of IV antibiotics are often administered prophylactically before surgery, and the regular elective course of IV antibiotics may be useful for patients who have experienced a rapid and progressive increase in the decline of their lung function or who suffer from frequent exacerbation. Implantable venous access device inserted in patients with difficult IV access or those needing frequent courses of IV antibiotics, usually assessed by trained nurse, patient, or family member, access only with a gribble needle of the appropriate length. Don't use standard needle, which may damage the intravenous access device, and do not attempt access intravenous access device unless you have been trained. Flush with 5 to 10 ml of 100 unit per ml heparin monthly and with 5 ml of 10 unit per milli heparin at the end of each IV dose. Avoid taking blood from intravenous access device if possible, as this increases the risk of blockage and infection, and other complications include venous obstruction, including superior vena cava obstruction, thrombosis, and dislocation, and leakage. If pain or swelling around intravenous access device site, arrange portagram or linogram to look for occlusion or damaged catheter. Antibiotic desensitization. Antibiotic sensitivity is a major problem in cystic fibrosis, as repeated antibiotic courses are associated with development of allergic reactions, especially to beta lactams, and rashes are common, but anaphylaxis can occur. Always give the first dose of a new antibiotic in hospital with resuscitation facilities at hand, and desensitization regimens can enable treatment with antibiotics that have previously caused an allergic reaction. Such regimes, such regimes need to be given at the start of antibiotic course each time it's used and during the course if doses are missed for more than 1 day. Depending on local policy, give a dilute antibiotic dose over 20 minutes, followed by a slightly stronger concentration, and repeat for 7 concentration strengths until full antibiotic strength is given. Take 3-4 hours, stop infusion if any side effects develop. Physiotherapy and cystic fibrosis. Specialized cystic fibrosis physiotherapists teach effective airway clearance with the aim that patients perform this themselves twice daily on a long-term basis. This improves secretion clearance, decreases airway obstruction, and improves ventilation. Several techniques are used: active cycle of breathing control, tidal volume breathing, then deep inspiration, and the passive expiration, followed by forced expiration to mobilize secretions prior to coughing or huffing. Autogenic drainage, a cappella or flutter devices, positive expiratory pressure mask, and use of NIV for airway clearance. That's all. Thank you.